We have almost 325 participants online eagerly waiting to have some more information. First, let me share the MCQs, and so that will give us an idea about how the participants have performed. So the first question is the Abraham-Griffiths number. What is the bladder outlet obstruction index? It's PDET at Qmax minus 2 Qmax. The second question is the most difficult for most of you, I believe, because of non-availability of UroLift in various parts of the world. And the question is, what is the urethral tab of UroLift made of? But those who have very attentively listened to Petro's talk, he did mention this. The urethral tab is made up of stainless steel, while the capsular tab is nitinol and the suture is a PET suture. It's very common to select titanium, which is one of the commonest implant used in orthopedics. A PSA level of 1.4 or higher indicates the increased risk of BPE progression. This is one of the commonest correct answer. This question is taken from the Scientific Basis of Urology. One of a very old book tells us about the basics, and following are the theories to explain the bladder neck opening, except all the theories were correct except the fourth one. The fourth one is simple hydrokinetic observation, just the change in the name. And this is to say what is normal. A normal person voids on an average about 300 ml completely in 40 seconds in 6 times a day. Unfortunately, as I said, none of the participants were able to answer all the 5 questions correctly. That's because of the question with UroLift in them. 3 of them answered all the 4 questions correctly. They are Neri Parajara from Paraguay, Mr. M. Anas Abu, and Firas Kana from Syria. Congratulations to them. They scored 4 questions out of 5. All 3 made the mistake only in the UroLift question. That shows the acceptance and availability of the minimally invasive technologies all over the world. I'm just going to ask few questions for the panel before jumping into the case scenarios. I don't want to really spend a lot of time in the case scenarios because we have few questions to ask from the participants. A question for Tanuj. What is the preferred laser settings for hole-up? Is there any advantage when compared to bipolar enucleation?
So most of the people actually prefer to operate at highest settings, that is 2 joules and 50 hertz. I personally prefer to operate at 1.5 joules and 50 hertz, and near the sphincter I prefer 1.2 joules and 50 hertz. So about 60 watts near the sphincter and about 75 inside the fossa is my preference, but I've seen that most of the people prefer to use higher wattage. Definitely over bipolar, the bleeding is lesser, enucleation is better, because most of the bipolar enucleations that I've seen are more of mechanical enucleations, and the bipolar is just used to coagulate. Whereas in laser, we use the laser energy to enucleate as well as coagulate. And definitely the stricture rates of bipolar that are higher than HOLA.
Thank you, Tanuj. Next question for Gayampalo Sena. The question is, what about the post-op incontinence and recovery post-resume?
So recovery is actually pretty fast. Patients are discharged 4 to 6 hours later. They go home with a catheter, and as we discussed in the presentation, the catheter is left in place for from 0 to 7 days, according to the case and the surgeon's preference. The side effects, dysuria and cystitis-like symptoms are the most likely adverse events patients can refer, but typically they can go back to work the next day with the catheter in case you place the catheter. So the recovery is pretty fast.
Okay, good. The next question is I want to direct to Hassan Kwasi. If there is a patient who is waiting for radical prostatectomy, but unfortunately has a 200cc prostate and he needs a bladder outlet obstruction surgery before going ahead, What is your choice? I know you will. You have robot, and you may even tend towards radical prostatectomy, which will tick both the boxes of de-obstructing the bladder and also the cancer treatment. But if he is heading towards radiation treatment, do you have any options for him?
So the answer is yes. We have had, interestingly, a couple of cases where men were heading for radiotherapy. We'd done prostate biopsies with a very elevated PSA, 27.4. And if you do a robotic simple prostatectomy, straightforward, the functional outcomes we've been able to demonstrate are very good. And in fact, the PSA dropped so significantly that it wasn't needed at all. So of course, this wasn't high-grade disease, it was Gleason 7 cancer. So number one, pre-radiotherapy, it would be no different, in my opinion, to anything else, like HOLEP or any of the other modalities. Yeah, you're absolutely right. Certainly, once you've got experience, size is not a consideration. In experienced hands for robotic radical prostatectomy, one can take on prostates of any size. The early continence, because of bladder neck reconstruction, tends to be a little more difficult, and nerve sparing can be a little more difficult, but it's not a contraindication. So in essence, you can do RRPs of any size. And number two, yes, it's a safe operation to do for disobstruction pre-radiotherapy.
Can I just, excuse me, can I comment on this, please? I actually asked this question. The question was, if a gentleman is not suitable for a radical prostatectomy but does have high-risk prostate cancer and has got significant voiding lower urinary tract symptoms with a relatively large prostate, and you want to optimize his lower urinary tract symptoms prior to radiotherapy, what are the options? And the reason I asked this is that this is a big prostate, and because it's an aggressive prostate cancer, HOLEP is often considered an unsuitable option because you can't find the layers. And I'm not sure if any of the other minimally invasive operations are necessarily suitable within this scenario. And this is one place where I think the conventional TURP may still be the only option you have.
Pavan, absolutely correct. Endoscopically, great. But that cohort of patients with aggressive prostate cancer and say a 200, 300 gram prostate, no one wants to look after. And I think as experienced robotic surgeons, people like you and I, we do have a role here. And this is where, even if you are not able to find a layer, and you are, of course, you cut into cancer, we've got amazing access to high pressure, we've got good access to bipolar diathermy, and actually, it works well. So I don't have a large experience, but we've done about 6 patients who've had prostate cancer, and the outcomes were good. So yeah, I think for people like you and I, that would be probably the way forward.
Good. The next question for the full panel, anybody can take up the question. If there is a relatively fit, say 76-year-old gentleman presents with chronic urinary retention, he attends A&E with inability to pass urine, bladder distended but not painful, catheterized, 1.2 liters of urine drain. So in this situation, if he has say 80 cc prostate with hypocontractile bladder, let's assume he had a urodynamically proven hypocontractile bladder, what is the choice of surgery?
Anand, if you're asking me?
Yes, sir. Anyone can.
I would do a TURP for him.
But we need to warn him regarding the post-op need for self-catheterization.
Yes. But we do know that men who have got an endoscopically large prostate, and even though they do have a hypocontractile bladder, their outcomes are better than somebody who has a smaller prostate and a hypocontractile bladder. And there's always this 50-50 chance that, and most of these guys actually void. And if they do have a residue which is, in the range of about 50-100 cc without incontinence or recurrent UTI, forget it, he's all right. He's happy, he's passing urine. He came with 1.5, he goes home with 100 cc in his bladder, it's okay. So I would go for a TURP.
I agree.
Yeah. But having said that, there are some good evidences to prove that whole knee enucleation also has a place, and it has a better de-obstruction, and sometimes patients' need for intermittent self-catheterization is a little bit lesser in frequency compared to relatively not very deobstructing surgery. Depends upon how good deobstructing we do. One question for Petros. A 45-year-old gentleman presents with history of voiding LUTS symptoms, and you do a flexible cystoscopy which shows just high bladder neck. There is not occlusive lateral prostate lobes. What is your choice, Petros?
Well, first of all, just to make a brief comment on the previous question, I would go for green light. Definitely something more destructive, if I may call, in terms of the prostatic tissue, rather than the other modalities. A big topic. Basically, you need to facilitate him if he resorts to intermittent self-catheterizations, open up the bladder neck. So that would be my choice. Now, coming to that question, we are aware of Peter Chin's work in Australia, where he demonstrated some modified procedures, combined BNIs and urolifts. So if the guy is extremely keen to preserve sexual function, probably antegrade ejaculation, I would go for a urolift. Now, we have some cutoffs. I mean, if the bladder neck is above a specific height as we view it in the cystoscopy, I wouldn't say that it can be very promising, but again, it depends on the patient's expectations. Dealing with him and explaining to them fully what to expect is of the essence. So if he agrees, we can try and do a combination of urolift and half of a BNI at 6 o'clock. He needs to be warned still that there could be, sorry, we said there was no BPE, just a bladder neck.
Yes, thank you.
Was that the question? Just BNI. Yeah. I would just go for a partial or a limited BNI. Now, we have some experience in our hospital, not many cases, I have to say, with a partial BNI, and it went well without compromising ejaculation. If there is a small element of BPE, then you can throw a couple of implants on iTrue. That will be the answer, the best suited option in my view.
Thank you, Petros.
Can I come in, Ananda?
Yes, please.
I think it's important that we have to. There's a simple principle that anatomy and physiology don't always go hand in hand, and therefore you really need to assess these patients urodynamically. You don't want to do an unnecessary operation with the hope that 50% will improve. So I think, if you only have a bladder neck which is high on cystoscopy, you really need urodynamics, video urodynamics even, to look at the bladder neck and see how it's opening during voiding and measuring the pressures. So I think, I don't think we should be operating on men just on cystoscopic examination, because we know physiology and anatomy are not always hand in hand. Yes, if the prostate was 100 grams, it's occlusive, then yes, you have a good chance. But if the prostate is small, then we need to assess the bladder neck.
Yes, I agree. Even the NICE guidelines for LUTS states extremes of age, those who are in 4th decade or nearing the 8th decade, it's better to quantify the bladder function and the overall bladder neck and other functions before we go for any bladder outlet obstruction. Ashim, when you're there, there is a question. We have, in evaluating of men with BPH, we come across erectile dysfunction as one of the findings. Sometimes the patients will overtly express them. Sometimes we need to really ask some pertaining questions to get it from them. We have IAEF 5 questionnaire, which is quite good for the clinical practice, and there is IAEF 15 questionnaire. Is there any role for IAEF 15 questionnaire in day-to-day practice other than the research or audit purposes?
I think sometimes you have to take a balance between practicality and research, really, and pragmatism. So IAEF probably does number five, does the trick for clinical practice. And I think the IAEF 15, you have too many questions. If you have the ICIQ and LUTS with 13 or 15 questions, and the IAEF with 15, and then you have other questionnaires, then the patients can have, and a bladder diary. You may get a lot of fatigue with questionnaire filling out. and therefore I stick with pragmatic. The ICIQ MLOTS is good. The IIEF is good. You combine them and you can get good data from that.
Thank you.
So I would stick with the IIEF.
Okay. So there are two more questions. Yeah. Go ahead, Hassan.
I absolutely agree with I would say that as long as we are checking, because we have a single stop, what's called rapid clinic, where men come in with a high PSA and have an MRI scan and get seen at the same day. And we started asking every single man, they all got an IPSS and an IEF sexual function questionnaire, and 40% had ED. They were embarrassed to talk about it, and that was one of the reasons that they'd gone to see their GP. So as urologists, we absolutely need to be aware of that very important aspect, which is also important in counseling men in terms of the treatments that we have to offer. And the second thing I would just say is all the treatments that we've talked about clearly work and are great. And I think for a lot of these patients, I could offer a robotic simple prostatectomy, but someone could offer HoLEP. So it really depends on your experience and expertise rather than the one treatment being the fix-all. Thank you.
Yeah. Thank you, Hassan. I have three more.
Can I just to finish? So, I apologize for the misunderstanding. I thought it was approved BOO, and we were at the previous question, and we're just focusing on urodynamics is of the essence. Yes.
Yes, Petros. Yeah. So we have three more quick questions before we close this session. The questions were for Maya Harris, Sachin, and Ganesh Gopalakrishnan, sir. So question for Maya. You have this green light, is it 180 watts laser? And if so, is it really advantageous compared to the older generation 120, Maya?
Oh, yes. If you have a larger prostate, what you do, you kind of work very delicately around bladder neck, and then you work delicately around the veru, and you end up with a kind of a BPH just prolapsing in there, and then you can whack up the power, and the prostate just melts. It disappears, on a high power setting. You cannot do high power setting, around the delicate areas. But when you're dealing just with the bulk, it's very much to the advantage. And the procedure goes quicker, and you are done, the patient out of the theater.
Thank you, Maya.
That's the advantage.
Yeah, that's all we want.
Yes, I like, high power setting, but you've got to be experienced because it could just melt through the tissue in a nick of time.
Good. So as long as our weapon is very powerful, we should be very careful in using it, as we say. Next question for Sachin. Sachin, you're called by your close urology colleagues that there is a 85-year-old gentleman bleeding from the prostate, 150 cc prostate, but not fit for any GA intervention, even a bladder clot evacuation. Do you think those patients in an acute setting bleeding will be suitable for prostatic artery embolization, especially if the vessels are okay?
Yes, absolutely. I think that's a good indication. And, for those type of patients, you don't need to be as selective, and you can use different types of embolic agents because you're not looking to cause, tissue necrosis. You're just looking to block the blood vessels, essentially. So you can use temporary embolic agents like gel foam. I think that's a good indication, and that's a good way for radiologists to start doing some prostate artery embolization. If they haven't got the other indications, they could start doing it for bleeding. I think that's a good way in.
Thank you, Sachin. And the last question is to the master of the masters, Dr. Ganesh Gopalakrishnan, sir. The question is, between the Freyers and Millin's open prostatectomy, which one is having less learning curve, or which one is more difficult to learn? Which is your preference?
Well, I think any day the retropubic approach is much better because you're sitting directly on the prostate. You don't have to mess about with the bladder at all, and especially we're talking about large prostates, so it comes out into the wound literally, and you're able to do a good job. I wouldn't say that there's too much of difference in the learning curve. There's always a fear that because the prostatic capsule has got the veins, that there will be more bleeding, but actually you can underrun these vessels before you actually make that transverse incision over the prostate capsule. Well, there's no doubt about the fact that when you're learning to do an open prostatectomy, the operation that is done is a Freya's, that is a transvesical prostatectomy. That's what is taught to you so that you get that plane of cleavage. But you can do it even the same way with retropubic. It's just that for some reason, there appears to be this difference in terms of difficulty index, but I don't see anything different.
Thank you.
I think it's about the same. Thank you.
Thank you. Thank you, everyone. Thank you very much for the panelists for sacrificing your 2.5 hours and also the preparation time on Saturday. Not a bad climate. We have pretty okay brightness in the daytime. And many thanks for the participants. We have almost more than 325 participants all over the world. And it's so glad to see that people are logging in from very remote locations. And I think, but for these kind of webinars, it's very difficult for them to understand what's happening in the real world. And whatever we read in the books or publications won't be equivalent to the word of mouth from the real practicing persons. We have tried our best to cover the complete armamentarium for BPH, but I'm very mindful that we have left aquablation and also the so-called old gold standard bipolar TURP. But we thought of dividing this whole seminar or webinar into like a part 1 and part 2, but we have made it into one. Thank you very much again for every panelist for your time, and hopefully we will see you again almost a similar webinar maybe in 1 year time, and by the time we will have at least 2-3 extra energy synopsis to discuss. Bye for now.
Thank you very much.